Thank you. Huge thanks to Archimed and for the organizers for inviting me to this webinar. It's always a great pleasure and privilege to continue my collaboration with Chile, which has started 30 years ago. So I'm going to talk about precision medicine, but I'll take a systems view of precision medicine. Thinking through, first of all, very briefly, say what precision medicine is as I understand it, then explore the promise of precision medicine, then look at some emerging innovations and possibilities, and think very importantly, as you said, Raphael, how can we create an environment, an enabling environment, an ecosystem to ensure that precision medicine is further developed and used to improve outcomes. So precision medicine is an approach that considers individual variability in one's genetic makeup, genotype, health status, lifestyles, socioeconomic characteristics, as well as the broader environment to enable targeted interventions that are highly personalized and precise. And to identify this variability, one uses biomarkers in screening and diagnosis during treatment and post-treatment, but also other data to identify variations in individual response to medicines and other interventions, and very importantly, outcomes. And precision medicine, as it has evolved, has focused on identifying single gene mutations or genetic drivers in subsets of patients, as Raphael highlighted earlier, then uses biomarkers and multiple molecular diagnostic tests to identify these subgroups, and then provides molecularly targeted therapies to these subgroups. So this enables or will enable us to transition from mass medicine to individual characterization, from developing interventions or medicines that are one size fits all to those that are highly targeted to subgroups or individuals. So there is great promise, because we're transitioning from an era where the treatments were anyone in the population, antibiotics, vaccines, hypertension treatments, where some groups benefited, some groups did not benefit very much, some groups had some side effects, and some groups had terrible side effects. As we transition to more targeted interventions and medicines for subpopulations, for example, in relation to medicines with monoclonal antibodies, for example, or biologics, we see a larger proportion of these subpopulations benefiting from the interventions, but far less side effects, or those who are not benefiting. As we transition to more and more precise interventions that take into account the variability in the genotype and the phenotype to greater extent, for example, through use of immunotherapy or gene replacement, we are entering the era of truly personalized health, where the vast majority of individuals benefit from the intervention, and very few do not benefit or have unintended consequences or side effects. But this is not just for medicine. We've been doing a lot of work to really understand how we can apply these principles at population level. This is a study that looked at hypertension care cascade in 44 countries, including these were nationally representative surveys in countries with individual biomarkers, so very precise. And the populations that the number of individuals involved in the study exceeded 1 million individuals, representing half the world's population. So a very large study. So we looked at, for females and males at different age groups and with different income levels, like no formal schooling, primary education, or secondary education, what happened at every stage of the care process in diagnosis, in control, those who are treated, and those who were controlled, including those initially whose blood pressure was ever measured. So at every step, we can identify for men and women, for different age groups, whether the blood pressure is measured, whether it's diagnosed, whether it's treated, or whether it's controlled. And we can see in the 44 countries in the world, in males, in the age group that is 15 to 24 years, with those whose treatment is achieving control is as low as 5%. Actually, it goes as low as 2% in those with just primary education, and reaches 4% in those with secondary education. In those who are age 65 years or more, we see that around 16% of the population included in the study achieve control. So we can tell very precisely which groups are at risk, but also which groups are benefiting from interventions. So this way we can apply highly targeted policies and interventions to these groups. And this is just, here we looked at age, sex, income, as well as education as predictors. But we can also look at geography, and we can also look at other characteristics. So this enables us to transition towards precision health. So the promise is really great. If we're able to make this transition, we can improve clinical effectiveness, we can improve efficiency of care, because we're targeting the right individuals at the right time. We increase patient responsiveness because interventions are highly personalized, and we reduce side effects. And the benefit of this is increased outcomes, both clinical outcomes and outcomes that matter to patients, but also huge economic benefits, because we reduce side effects, we reduce unnecessary interventions, and we achieve good outcomes. So what are the emerging innovations? Now, I'll focus just on precision medicine as opposed to precision health at population level, but there have been several medicines that have been used successfully. For example, trastuzumab, a monoclonal antibody for HER2-positive individuals with breast cancer, ivacaftor, a gene-based therapy for cystic fibrosis, Gleevec that has been widely used, again, a targeted therapy for myelogenous leukemia and acute lymphoblastic leukemia. And more recently, we see Strenvelis, a gene therapy for combined severe immune deficiency, and CAR T cells, immunotherapy that is highly personalized, highly individualized, and that have been used for refractory non-Hodgkin lymphoma and refractory acute lymphoblastic leukemia. And the list is expanding, so the potential is really great. But the challenge is, while we have remarkable innovations and developments in biomarkers and targeted treatments, the ecosystem is not ready. We still don't have enough understanding of the genotype and phenotype heterogeneity. The biomarkers are not as well developed as they could be. Data on and evidence on outcomes and costs are not present in most countries. So we don't really have capable health systems that can manage the whole care process effectively. And important considerations that we have to create an enabling ecosystem for innovation for this, and that's not present in many settings. And appropriate regulations are not in place that focus on payment for value. But there are a number of transitions that will help accelerate to move towards precision medicine and precision health. The first transition is digitization of data and healthcare generally. So we're now able to combine data from genomic, proteomic, cellular level all the way up to an individual level with data on the data in relation to the healthcare process for individuals, from prevention and screening, diagnosis and risk profiling, treatment and care at different settings, at home, in the community, in hospitals. Then we can bring these data together into a large data set and use data mining techniques, analytics, and process automation, and analyze how individuals are responding to a particular intervention or how they are progressing in the care process. Using that iteratively, we can develop decision support systems with better risk profiling, with more and more precise stratification of population groups. Now, this can be taken a stage further by incorporating into this machine learning and artificial intelligence that can enable us to develop real-time, dynamic, interactive care through the use of digital care pathways, and also an approach that can enable resource optimization. Now, if we can put these digital systems in place, we can improve the sensitivity and the specificity of the interventions that are being applied and increase the precision of the interventions for subgroups. The second transition is a move from providing just a medicine or an intervention to providing solutions. For example, therapy plus solutions with some services, or a bundle of packages for a single episode of care, or a bundle of services over a period of time for a single condition, or actually taking that a stage further, providing a set of solutions for a series of related conditions. For example, hypertension, ischemic heart disease, diabetes, hypercholesterolemia, over a period of time, focusing on the individual multi-disease bundle, or focusing on subpopulations and managing a multitude of risk factors and conditions simultaneously. So there's this transition towards the traditional approaches to providing ingredients to providing solutions to individuals or combined diseases or even subpopulations. The third transition is automation. And Raphael mentioned participation as an important and critical component of this transition to personalized medicine and health. And COVID-19 has accelerated the use of conversational agents or even robots that can interact with patients using chatbots or chatbots with artificial intelligence, or even conversational agents that can enable greater engagement in the care process to improve outcomes. That is also a major transition that a number of countries are already applying. And the fourth transition is at health system level, where we're transitioning from paying for structures, for example, allocating budget to a hospital or a primary care center, or paying for a medicine or a diagnostic, to transition to what I call a functional focus, where payment follows activity, providing a set of interventions, for example. Or the next stage, which many countries are transitioning to, is the value focus, where payment follows value, creation of value for improving outcomes at individual level or at population level. So this transition in payment systems or financing models is also critically important. So these four transitions put together there's an opportunity to really accelerate the move from traditional approaches to treatment and care to new approaches that are much more precise at individual and subpopulation level. And in relation to value focus, there have been a number of important developments recently. And by value-based healthcare or health systems, I mean putting in place a number of critical components. So digital systems with real-time analytics, as I mentioned, the stratification that allows risk adjustment and identification of subgroups, development of interventions with bundling of care, outcome-based payment methods, and integrated provider networks so that care is provided not just in one domain, but throughout the patient journey. And very importantly, behavior change on the side of the providers, payers, and those who are benefiting from services. And at the last G20 meeting, actually, the current G20 presidency, which ended a few weeks ago, value-based health systems was recognized as an important priority for G20 countries. The G20 leaders' declaration said that well-functioning, value-based, inclusive, and resilient health systems are critical for achieving universal health coverage. And G20 has established a global innovation hub for improving value health in health. So that provides further impetus in the transition that is already happening. So what can we do to try and put together these transitions to create the synergies to accelerate adoption and diffusion of precision medicine? So we need to create an innovation ecosystem that enables the generation of precision medicine approaches, but also their use. First, we need to ensure that universities are involved in this process, because universities are the hubs for science. But working with industry to enable development of these inventions and ideas and translate them into usable products and solutions. But very importantly, we also need the engagement of the health system, healthcare providers that can provide the setting for the application and diffusion of these innovations and their iterative refinement and development. So if we can bring these three entities to work together through new partnerships, we can transition from invention to innovation at scale to ensure benefit for individuals, but also for populations. And a number of countries are moving in this direction. For example, in the US, there's the Precision Medicine Initiative, and that has mobilized 1 million volunteers. And the initial focus of this is cancer, but it will be extended to other conditions. And this involves establishment of biobank, engagement of citizens, systems for data capture, data integration and linkage and analytics, involvement of healthcare providers for application of these solutions, a participant center to ensure there is real-time response to questions, and technology to enable linkage among all the participants. And this is linked to additional work with genomics to combine genotype and phenotype characteristics. In addition to the US, we're also seeing similar initiatives in the United Kingdom with Genomics England that has put in place a program of work with the ambition of whole genome sequencing of 5 million individuals. And again, this involves multiple actors from universities, other research centers, funders, the National Health System that provides the care, as well as the Medical Research Council that funds some of these initiatives. In addition to the UK, there's also in France, and of course, these are purely illustrative examples. There are other countries that are moving in this direction. In France, there is the Genomic Medicine 2025 initiative that has brought together a network of 12 sequencing services with the ambition of whole genome sequencing of around 250,000 genomes each year from 2020 to 2025. Again, this is underpinned by data systems and analytics to understand better genotype variations and phenotype variations. So there are a number of initiatives, a number of transitions that will help accelerate the adoption and diffusion of precision medicine and precision health. But for that to happen, an ecosystem needs to be created at each country to accelerate and realize benefits. Thank you very much for your attention. Now, in the future, if we can make this transition, there will be just one health intervention, yours.
Thank you. Thank you so much, Professor Atun. Okay. I think please remember that I will be collecting your questions in the chat for delivery to Professor Atun. Bien, muchas gracias, profesor, por su presentación.